Good morning, everyone. Today I will be talking about fluid compartments and how fluids are distributed in the human body. Water is the main solvent in our body and is essential for maintaining hemostasis. All electrolytes and substances are dissolved in this medium, so understanding the fluid distribution is very important in the clinical practice. Now, this slide highlights why water is so important. First, the water is essential, which makes the major portion of our body. And secondly, the cell membrane separates the fluid into compartments, that is inside and outside the cell. Third, various hemostatic mechanisms regulate water and electrolyte balance. So, in critically ill patients, this balance is often disturbed. So, understanding these principles help us to manage the fluids better. Total body water varies with age and gender. In neonates, it is around 80%, which gradually decreases as the age increases. In adults, it is about 60% in males and 50% in females. In elderly, it further decreases. So, when we prescribe fluids, we must consider age, gender, and body composition. To understand the fluid distribution, we take a standard 70 kg adult male. So, in the 70 kg adult male, the total body water is about 42 liters. Out of this, around two-thirds, that is about 28 liters, is intracellular fluid, which is a major portion. The remaining one-third is about 14 liters, is extracellular fluid. This extracellular fluid is further divided into interstitial fluid, plasma, and a small amount of transcellular fluid. Now, extracellular fluid acts as an outer environment for cells. It makes up about one-third of the total body water. It is separated from intracellular fluid by the cell membrane. So, ECF is divided into interstitial fluid, that is fluid between the cells, and intravascular fluid, that is the plasma, and transcellular fluid like CSF and pleural fluid. Clinically, most IV fluids we give initially expands this extracellular compartment. Now coming to the interstitial fluid, which is the largest component of the extracellular fluid. It is about 9.5 liters. It is present in the space between blood vessels and the cells. Functionally, it acts as a communication between the intravascular compartment and individual cells. It allows the exchange of nutrients, oxygen, and waste products. Its electrolyte composition is almost similar to the plasma, but it contains a very little protein. So, traditionally, we believe that fluid filtration occurs at the arterial end of the capillaries and reabsorption at the venous end. However, the newer concept suggests that there is a continuous filtration along the most of the capillary length, with lymphatics playing a major role in returning the fluid. This shift is important because it changes how we understand the edema formation and fluid therapy. Interstitial edema. It occurs when fluid accumulates excessively in the interstitial space. There are four main mechanisms. First is the cardiac failure, next decreased albumin, increased capillary permeability, and impaired lymphatic drainage. Understanding these mechanisms help us to identify the cause and guide the treatment. First, cardiac failure increases the venous pressure, pushing the fluid out of the blood vessels into the interstitial space. And second is decreased albumin. It reduces the oncotic pressure, so fluid cannot stay within the vessels. Both these mechanisms lead to fluid accumulation outside the vascular space. Third, increased capillary permeability, commonly seen in the sepsis. It allows the fluid to leak freely into the tissues. And fourth, impaired lymphatic drainage. It prevents the removal of interstitial fluid. So overall, edema results from either increased leakage or reduced clearance of the fluid. Now coming to the intravascular compartment, which is the fluid present within the blood vessels. This compartment contains whole blood, which includes plasma and blood cells. The total circulating blood volume is approximately 5 liters in an average adult. Out of this, plasma volume is about 3.5 liters and remaining 1.5 liter consists of blood cells, mainly of red blood cells. Clinically, this is important compartment for us because maintaining an intravascular volume is essential for perfusion and blood pressure. Next comes the transcellular fluid. It is a small but clinically important compartment. About 1 liter of volume is present as a transcellular fluid. These fluids are present in specialized spaces lined by epithelium such as CSF, pleural fluid, peritoneal fluid, and synovial fluid. Their composition varies depending on the function of that space. In disease states, these compartments can expand significantly. For example, of like a pleural effusion, ascites, and pericardial effusion. Now, this slide shows the variation in the electrolyte composition across the different transcellular fluids. For example, gastric fluid is rich in hydrogen ions and chloride, while pancreatic fluid is rich in bicarbonate. CSF has a similar composition as plasma, but it has a lower protein. Here, the key point is that each fluid is specialized for its physiological role, so their electrolyte composition differs significantly. Now, coming to intracellular fluid, which is the largest compartment of the total body water. In a 70 kg adult, total body water is about 60% of the body weight, and two-thirds of this is 28 liters, which is the intracellular fluid. This fluid is contained within the cells, and this is tightly regulated by the cell membrane. The intracellular environment is crucial for cellular function, and even a small disturbance can affect the cell survival. Now, how do we measure the body fluid compartments? The basic principle is the indicator dilution method. We administer a known quantity of substance and measure its concentration to calculate the volume. Volume equals mass divided by concentration. An alternative method is bioimpedance spectroscopy, which estimates the body fluid by measuring the resistance to electrical current. These methods are mainly used in research and specialized clinical settings. To accurately measure the body fluid compartments, we use indicator dilution techniques. An ideal indicator should meet certain criteria. First, it should remain confined to the compartment being measured. Second, it should distribute evenly throughout that compartment. Third, it should have a predictable elimination kinetics. It must be a non-toxic, and importantly, it should not alter fluid balance or osmotic gradients. These properties ensure accurate and reliable measurement of fluid volumes. So, different compartments are measured using different indicators. Total body water is measured using isotopes like tritium and deuterium. Extracellular fluid can be measured using substances like inulin or mannitol, although they may slightly underestimate the volume. Plasma volume is measured using a labeled albumin or a dyes like Evans blue. Red cell volume is measured using chromium labeled RBCs. From these, we derive other compartments. Interstitial fluid equals extracellular fluid minus plasma volume, and intracellular fluid equals total body water minus extracellular fluid. Although the composition of intracellular and extracellular fluid, uh, although the composition of intracellular and extracellular fluids are very different, they exist in osmotic equilibrium. In extracellular fluids, sodium and chloride are the dominant ions. In intracellular fluid, potassium and magnesium are predominant. This balance is tightly regulated to maintain the cell volume and function. Now, this slide highlights the difference in the electrolyte concentrations. Sodium is high in the plasma and low inside the cells, whereas potassium shows the opposite pattern. It is high in intracellularly and low in plasma. Similarly, proteins and phosphates are mainly intracellular, while chloride and bicarbonate are extracellular. These gradients are essential for a membrane potential and cellular activity. Now, intracellular fluid is the largest, about 28 liters, and it is rich in potassium and proteins. Extracellular fluid is about 14 liters. It is rich in sodium and chloride. It is further divided into interstitial fluid and plasma. Transcellular fluid is small but clinically important. Understanding these volumes, compositions, and measurement methods will help us to manage the fluid and electrolyte disorders effectively. Now we move into the core physiology, how the fluid actually moves across the membranes. This includes both cellular mechanisms and capillary level dynamics, especially the shift from classic Starling model to the modern glycocalyx based understanding. Fluid movement in the body is governed by the balance of hydrostatic and osmotic forces across the semipermeable membranes. At the cellular level, transport occurs via ion channels, pumps, and osmosis. At the capillary level, the traditional Starling model describes filtration at the arterial end and reabsorption at the venous end. However, the modern concept emphasizes the endothelial glycocalyx as a primary barrier. This shifts the understanding towards the continuous filtration with minimal reabsorption, and lymphatics play a major role in returning the fluid. Clinically, when glycocalyx is damaged, like in sepsis or trauma, we see increased permeability and interstitial edema. Water crosses the cell membranes through two main pathways. First is direct diffusion through the lipid bilayer, which is relatively slow. Second, and more important, is via aquaporins, a specialized water channels that allows the rapid movement. These are highly regulated. For example, vasopressin increases the aquaporin insertion in renal collecting ducts, enhancing the water reabsorption. So, clinically, ADH directly influences the water balance at the cellular level. The primary driving force for the water movement is osmotic pressure. Water moves from areas of the low solute concentration to the high solute concentration. But clinically, what matters is the tonicity, which, which depends on the effective osmoles. Effective osmoles like mannitol stay in one compartment and pull the water. Ineffective osmoles like urea freely crosses the membrane and do not create sustained gradients. Glucose is conditionally effective as it acts as an osmole in the absence of insulin. As we can see, as seen in the DKA, in diabetic ketoacidosis, it acts as an osmole. This concept is critical in fluid therapy and interpreting the sodium disorders. Hydrostatic pressure refers to the physical force exerted by fluid against the vessels or compartment walls. It drives the fluid outward, especially in the capillaries. At the cellular level, electrochemical neutrality must be maintained. This is governed by the Gibbs domain effect, where impermeant intracellular protein influences the ion distribution. The sodium potassium ATPase pump plays a key role. It actively pumps three sodium ions out and two potassium ions in. This maintains ionic gradients, which indirectly regulate the water movement and cell volume. At the capillary level, this is where the most important fluid exchange happens. Capillaries form the extensive network with a massive surface area, allowing efficient exchange between the plasma and interstitial fluid. Electrolytes and small solutes move freely, so plasma and interstitial fluids have nearly identical ionic composition. However, proteins largely remain intravascular. This becomes crucial in understanding the oncotic pressure. Now the key question is how exactly does the fluid moves across this interface? This is explained by two models, the classic Starling model and the modern glycocalyx model. Traditionally, the fluid movement across the capillaries was explained by the balance of two opposing forces. One is hydrostatic pressure, which pushes the fluid out of the capillary. Oncotic pressure, generated mainly by the plasma proteins, it pulls the fluid back into the capillaries. Fluid and solutes pass through the endothelial pores between the cells. So essentially, capillary exchange was thought to be simple mechanical balance between push and pull force. So to quantify this, we use the Starling's equation. Net fluid movement depends on the hydrostatic pressure gradient minus oncotic pressure gradient. Kf represents the capillary permeability and surface area. Sigma reflects the coefficient. It tells us how well the protein are retained within the capillary. If the sigma is close to 1, proteins are retained, like in the brain. If it is lower, proteins can leak out, like in the inflamed tissues. So this equation integrates the pressure, permeability, and protein behavior. So based on this model, the prediction was at the arterial end, hydrostatic pressure dominates and filtration occurs. At the venous end, oncotic pressure dominates and reabsorption back. About 90% of the fluid returns to capillaries and 10% via lymphatics. However, this model has a major limitation. It assumes the capillary wall is just a simple semi-permeable membrane, ignoring its biological complexity. And this is where the modern understanding changes everything. Now come to the modern concept of the endothelial glycocalyx. This is a gel-like layer lining the inner surface of the capillaries, composed of glycoproteins and proteoglycans. It is a natively charged and acts as a true barrier, not the endothelial cells themselves. It selectively restricts the proteins and cells while allowing the water and small solutes to pass. So instead of small pores, we now have a dynamic biological active filtration barrier. Under the modern glycocalyx model, the fundamental concept of the capillary exchange changes. Instead of filtration at the arterial end and reabsorption at the venous end, filtration occurs throughout the entire capillary length. There is no significant reabsorption at the venous end under steady state conditions. The filtered fluid accumulates in the interstitium and is written almost entirely via lymphatic system. So lymphatics are not a backup, they are the primary return pathway. This is where the biggest conceptual shift happens. Traditionally, we thought oncotic pressure gradient was between the plasma and interstitial fluid, but this is not correct. The true opposing forces is across the glycocalyx, specifically between the plasma, that is OC, and subglycocalyx space, OSG. Now the key point is the subglycocalyx space has very low protein concentration, much lower than that of the interstitial fluid. So the effective oncotic gradient is smaller than we previously assumed. This means the pulling force back into the capillaries is weak. Hence, reabsorption is minimal or absent. Let's summarize the shift. Capillary wall is no longer a simple membrane, it is a biological gel barrier. Reabsorption is not 90%, almost none occurs. Lymphatics is not a minor, they handle nearly all the return, that is reabsorption. Oncotic gradient is not plasma versus interstitial fluid, it is between the plasma versus subglycocalyx. This fundamentally changes how we understand the edema and fluid therapy. This has a massive clinical implications, like in conditions like sepsis, severe trauma, burns, ischemia, reperfusion injury. Here the glycocalyx gets degraded. Once the protective layer is damaged, capillary permeability increases. Protein leaks into the interstitium. Oncotic gradient collapses. Filtration becomes uncontrolled, which results in a massive interstitial edema. This is the pathophysiology of the third spacing. This explains why giving a large volumes of crystalloids in sepsis worsens the edema. Albumin may not work if glycocalyx is damaged. So fluid responsiveness is not equal to fluid tolerance. So we must be cautious with fluid resuscitation. Capillary dynamics are also influenced by the vascular tone. In anaphylaxis, massive vasodilation, increased capillary hydrostatic pressure, rapid filtration, sudden edema, and hypotension. This is why patient crashes quickly. So now adrenaline reverses this. It causes precapillary vasoconstriction, and it reduces the capillary hydrostatic pressure, decreases the filtration, improves the hemodynamics, and reduces the edema. So adrenaline is not just a vasopressor, it directly modifies the capillary fluid dynamics. Now let's zoom into and take a look at the big picture. Fluid hemostasis. is not just about capillaries. It is a multi-level system involving cellular membranes, capillary exchange, neural and hormonal regulation. At the center of all these is extracellular fluid volume, which determines the perfusion. Now, this slide summarizes the most important principle. The body maintains a balance between intracellular fluid and extracellular fluid. Extracellular fluid is sodium dominated, intracellular fluid is potassium dominated. Water shifts freely between the compartments based on the osmotic gradients. So, simply to remember, sodium controls the extracellular fluid volume and water follows the sodium. The body continuously monitors the circulating volume using a stretch receptors. These stretch receptors are located in atria and large veins. When the volume increases, the stretch increases. Then the signals are sent via the vagus nerve to the brain. This acts like a brake system to prevent the fluid overload. When the atria is stretched, they release atrial natriuretic peptide ANP. ANP acts to reduce the volume by increasing the sodium excretion natriuresis and causing the vasodilation and inhibiting the RAAS and vasopressin. Therefore, the net effect will be decrease in the extracellular fluid volume. On the opposite side, we have the alarm system. In hypovolemia, the sympathetic nervous system is activated. This leads to renal vasoconstriction, reduce the GFR, activation of the renin-angiotensin system. This finally results in the sodium and water retention. Now let's move to one of the most important volume regulating systems, that is the renin-angiotensin-aldosterone system. This system is activated in response to renal hypoperfusion, sympathetic stimulation. So this system actually responds to renal hypotension, hypoperfusion and sympathetic stimulation, that is the beta 1 activation. So this triggers renin release at juxtaglomerular cells. This renin initiates the cascade leading to the angiotensin 2 formation, and angiotensin 2 is the key effector. This angiotensin 2 will do two critical things. First one is the vasoconstriction. It increases the systemic vascular resistance. And second, it stimulates the adrenal cortex by release and releases the aldosterone. Therefore, the net effect is raised blood pressure and restore the perfusion. Now comes the aldosterone, the volume expander. It is released from the adrenal cortex under angiotensin 2 stimulation. Its action is it increases the sodium reabsorption in distal nephron. Water follows the sodium. This leads to increased intravascular volume and increased extracellular fluid volume. So far we have discussed volume. Now let's talk about osmolality control. Plasma osmolality is primarily determined by sodium concentration. This system is triggered by hyperosmolarity, hypovolemia. So these changes are detected by osmoreceptors in the hypothalamus, which then controlled by vasopressin release from the posterior pituitary. So vasopressin is the body's fastest acting water regulator. It is released from the posterior pituitary. It acts within the minutes. Its half-life is 15 minutes. This allows precise and rapid control of fluid balance. This is why ADH is crucial in acute states like shock, dehydration, and postoperative states. Now let's see how vasopressin actually works. It acts on the V2 receptors in the kidney, that is in the collecting ducts. This leads to insertion of aquaporin 2 channels and increased water permeability. Therefore, water is reabsorbed back into the circulation. This results in concentrated urine, increased blood volume, and rapid restoration of the circulation. Now, let's bring everything into a single framework. Think of fluid balance as being controlled by three major hormonal valves. Those are ANP, aldosterone, and vasopressin. Each hormone responds to a different trigger. ANP is triggered by volume overload, that is the atrial stretch. Aldosterone is triggered by RAAS activation, and ADH is triggered by hypovolemia or increased osmolality. So, and coming to the reactions, each act differently. ANP excretes the sodium and vasodilates, therefore it reduces the volume. Aldosterone, it retains the sodium and expands the volume. ADH, it retains the water and restores the circulating volume. So therefore ANP, simply saying that ANP, it drain the tank, aldosterone, it fill the tank, ADH, it adjusts water concentration. So to understand fluids, we must go back to the basics. A solute is something that dissolves. A solvent is the liquid that dissolves it. When solute dissociates, it has cations and anions. Cations are the positive ions like sodium and potassium. Anions are negative ions like chloride. Sodium is the most important extracellular cation. When this wherever the sodium goes, the water follows. This is the single important rule in the fluid therapy. Now let's talk about osmosis. Water moves from low solute concentration to high solute concentration. And coming to osmotic pressure depends on number of particles, not their size or charge. So one sodium is equal to one calcium in osmotic effect, for example. This is why even a small change in the sodium will lead to major fluid shifts. So these two are commonly confused but clinically important. Osmolarity and osmolality. Osmolarity is the osmoles per liter. It is a volume based. Osmolality is osmoles per kg. It is a mass based. In ICU, we use osmolality, but not affected by the temperature or volume shifts. In ICU, we use osmolality because it is not affected by temperature or volume shifts. Normal plasma osmolality is 275 to 295 milliosmoles per kg. Now comes the important concept, that is the tonicity. Tonicity depends only on the effective osmoles. Effective osmoles are those that cannot cross the cell membrane. Examples of effective osmoles are sodium. Sodium stays extracellular and causes the water shift. Ineffective osmoles are, like example is urea. It crosses the membrane, so there will be no sustained shift. So these osmoles pulls the water into or out of the cells and determine the cell swelling or shrinkage. This is why in hyponatremia there will be a brain swelling. In hypernatremia there will be a brain shrinkage. Not because of the volume, it is because of the tonicity. Not all osmoles are equal. Only effective osmoles create a sustained water movement across the cell membranes. Effective osmolytes, these substances cannot freely cross the cell membrane, therefore they remain in the extracellular fluid. So they pull the water across and cause the true osmotic shifts. Example, sodium, which is the most important, mannitol, and glucose. Glucose, when insulin is deficient, it acts as an effective osmol. Ineffective osmolytes, as we discussed earlier, these cannot cross the membranes easily. Those are urea, ethanol. These can ineffective osmolytes can cross the membranes easily. They are urea, ethanol, methanol. They equilibrate across the compartments, so they do not cause sustained water shifts. This is why urea increases the osmolality, but does not cause the cerebral edema or dehydration. In clinical practice, we estimate the osmolality using a formula. The main key driver in this formula is the sodium. The calculated osmolality, the formula is 2 into sodium plus glucose by 18 plus BUN 1 by 2.8. Here, why sodium is doubled? Sodium is paired with anions, chloride plus bicarbonate. So we multiply by 2 to reflect the total osmotic contribution. BUN is included, but remember it is an ineffective osmol. Now we refine further. What really matters clinically is effective osmolality. So we can use the effective osmolality formula as 2 into sodium plus glucose by 18. We exclude BUN. Why? Because urea crosses the membrane, it does not drive the water shifts, so it is irrelevant to tonicity. So therefore the normal effective osmolality is 275 to 290 milliosmol per kg. This is what the brain senses, not the osmolality, but effective osmolality. Now comes the powerful diagnostic tool, the osmolar gap. The osmolar gap is defined as a difference between measured osmolarity minus calculated osmolarity. Normal value is less than 10 milliosmol per kg. When increased, if the gap is high, there are unmeasured osmoles present. For example, the common causes are alcohol like ethanol, methanol, ethylene glycol, and mannitol, and toxic ingestions. In ICU, if we find a high osmolar gap, think of poisoning or exogenous osmoles. Now let's integrate the everything into one final framework. The system, the fluid balance depends on a regulatory pathways, RAAS, ADH and ANP, and physical forces like osmosis and tonicity. Clinical states, disease alters both regulatory pathways and physical forces. So this is not a one system working alone, it is a symphony of electrolytes, cell membranes, hormones, capillary dynamics, and all together. Ha- In ICU practice, we must understand which compartment is affected, whether it is volume versus tonicity problem, whether osmoles are ineffective, or whether it is osmoles are effective or not. We have to look at whether osmoles are effective or not. Thank you.